Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hey everyone, welcome back to a CardioNerds case report. This is Amit Goyal back with Dan Ambinder, and we are so thrilled for this case, the very first case from colleagues at the University of Southern California Keck School of Medicine. We are joined by Dr. Emily Lee and Dr. Charlie Lin to teach us about cardiology. So guys, welcome to the show, and would you please introduce yourself?
Hi, my name is Emily Lee. I am currently a PGY2 internal medicine resident at Keck School of Medicine. I am interested in going into cardiology in the future.
Hi, thanks for having us. I'm Charlie Lin. I'm one of the general cardiology fellows here, and I'm hoping to have a future in electrophysiology.
Well, Charlie and Emily, welcome. This is so exciting. And for Amit and I to both be on the CNCR recording, it's even an extra bonus. And we love the West Coast. So speaking of, it's probably sunnier than where we are sitting here, but please take us to your favorite spot in LA so we can have a great conversation about cardiology.
Sure. So today in the sunny California, I would like to take you on a waterfall hike to Pasadena after all the recent rain we actually got here. And then after that, we will be taking a stroll through the neighborhood for a nice brunch.
Friends, that sounds absolutely lovely. Count us in, and let's get started.
All right. Today, we will be taking you to our emergency department at LA County Hospital. So our case is a 33-year-old male. He's presenting to the emergency department with progressive lower extremity edema for the last 2 months and dyspnea on exertion for the past month, and that was worse over the past week. And just some additional information. So regarding his lower extremity edema, he says that it is bilateral and has been getting worse, making it difficult for him to walk and to work. Previously, he had no limitations in his physical ability, but over the past month, he feels short of breath with walking 3 to 4 blocks, and over the past week after walking 1 to 2 blocks. His mom, who was also present, notes that he wakes up throughout the night gasping for air. He does snore when he sleeps, but has never had a sleep study done in the past. He also reports having intermittent palpitations and chest pain during the day. Of note, he was diagnosed with left lower extremity DVT approximately a year ago, and it was thought to be due to long periods of immobilization with weekly bus rides from Los Angeles to Las Vegas. He was prescribed apixaban for 6 months, though he reports he stopped taking it after 6 weeks since he attributed the medication to significant nausea. Regarding his other review of system, he denied any fevers, chills, headache, vision changes, and abdominal pain. Jumping into his past medical history, he has a history of hypertension and provoked left lower extremity DVT, as we mentioned. For his medications, he was previously on apixaban and lisinopril, but again, he has stopped both of those medications at this time. And regarding his social history, he drinks 2 to 3 beers on the weekends. He reports infrequent tobacco use, and he has extensive methamphetamine use, approximately 0.5 gram per day to day and a half. For his family history, both his maternal and paternal grandparents have hypertension, type 2 diabetes, and CKD, and the patient has no known drug allergies.
Hey, Emily, can I ask while we're going through this history, for those of us who don't know, where does 0.5 gram of methamphetamine per day stand on the scale of very little, medium, a lot? I really have no concept of this amount.
Yeah. I actually had to look this up because the patient didn't tell me, but usually 0.2 to 0.3 grams for every 12 hours is what's typical. So he's been using it for about 2 years already. So I think he increased the dose a little bit for himself to get the same high.
Yeah, so it seems like a pretty robust use of methamphetamine. And by the way, terrific history that really gives us a sense of alarm in this otherwise fairly healthy and young gentleman, right? I mean, he's had quite rapidly progressive dyspnea on exertion over a handful of weeks, which as a young person without too many risk factors, you would think the cardiopulmonary reserve is fairly high, right? For someone to start having functional limitation, something very serious is going on. And you would think, okay, is this cardiac, pulmonary, hematological? The fact that he's had a prior DVT might help us start honing things in. I know that we considered long bus rides as a possible risk factor, but we'll have to dig into this a bit more. But thanks for a terrific history. What were you guys thinking about at this point?
So the patient's presentation with dyspnea is a very common symptom that we see in the outpatient setting and in hospital emergency rooms because it is caused by so many different underlying conditions, some of which arise acutely and can be life-threatening like a PE or an MI. A thorough history and targeted diagnostic studies are very important. Overlapping clinical presentations and patients' other comorbid diseases can make the diagnostic evaluation of dyspnea very difficult. And sometimes the presence of dyspnea alone is already a predictor of increased mortality. So when we think of dyspnea, way to more precisely characterize the patient's symptoms are very helpful when we're trying to come up with the targeted differential diagnoses. So some criteria that we should consider include, is there a temporal component? So is it acute, meaning it's less than 4 weeks? Is it chronic? Is it present for more than 4 weeks? Or is it acute on chronic issue? Alternatively, does it happen only intermittently, or is it more permanent? The next criteria to consider is there a situational component? Does it happen at rest or when the patient is exerting themselves? Does it accompany any emotional stress? Does it depend on the patient's body position? So if they're sitting up, lying down, or does it depend on where they're located? Does it only happen at work, at home, when they're near pets? And lastly, to consider what other systems are associated with it. So do we think it's a problem primarily related to the heart? Or do we think it's primarily related to the lungs? Or is it a mix of a lung and a heart issue? And there's other causes that we need to consider for dyspnea, including anemia, thyroid diseases, or patient's poor physical condition, as well as any mental health causes. So just some initial differentials for our patient's dyspnea, palpitations, lower extremity edema, as well as his history of untreated DVT. We already mentioned a few, but just to add on, so the patient could have a new diagnosis of decompensated heart failure. He could have a cardiac arrhythmia. He could have a pulmonary embolism. He could have pulmonary arterial hypertension. He could have chronic thromboembolic pulmonary hypertension, as well as anemia. And lower on the differentials, but we should always have in the back of our minds, includes acute coronary syndrome secondary to vasospasms, pericarditis, pericardial tamponade. He could have a respiratory infection like pneumonia, or he can have underlying asthma or COPD that have yet to be diagnosed.
Emily, a wonderful differential. And at this stage, this individual is presenting as a pure medicine type admission de novo with these rapidly progressive symptoms, which are certainly concerning. And in cardiology, we outline several of the concerns that you have already touched upon. Namely, have we thought about the electrical conduction of the heart, the coronary arteries, the function of the valves and the myocardium itself, as well as the pericardium? But outside of this, you've also highlighted some of the very common causes for dyspnea, including the pulmonary system, as well as the hematologic system. I think all these are worth looking into for a young individual who otherwise presents with some vague history of substance misuse and otherwise not much prior workup. So as he's behaving more of a cardiopulmonary type patient, what is your thought process in terms of sequence of workup? What do you do next? What do you reach for first?
Sure. Next, I would go to the vitals and the exam and then hopefully get a chest X-ray or an EKG. We can get on the spot to start working him up. Our patient's vitals on admission, his temperature was 37 degrees Celsius. His blood pressure was 152/96 with a MAP of 115. His heart rate was 104. His respiratory rate was 22. At room air, the patient was satting 91%, and he improved to 97% with 3 liters nasal cannula. First physical exam, the patient appeared in mild distress with deep inspiration and with speech, but otherwise he was resting comfortably while he was sitting upright. It was difficult for me to appreciate any jugular venous distension. For his cardiac exam, he had normal S1, S2. He had no significant murmurs, rubs, or gallops. He had mild crackles at the lung bases. Otherwise, no wheezing or rhonchi was appreciated. And he was using 3 liters nasal cannula. His abdomen was soft, non-tender, mildly distended. Regarding his extremities, he had 2 to 3 plus bilateral lower extremity edema, those equal on both sides and up to the knees. For his neuro exam, he was moving all his extremities. And for his psychiatric exam, he was alert and oriented ×3. Now jumping into some of the labs that we have. Regarding his CBC, he was notable for mild thrombocytopenia to platelets of 151. Regarding his CMP, his creatinine was a little bit elevated to 1.25 with the baseline of 1 to 1.1. Jumping into our cardiac biomarkers, his troponin T was 0.01 on admission. Then 4 hours later, it was less than 0.01. His NT-proBNP was 1,868, but there was no baseline available. His thyroid studies were unremarkable. His venous blood gas was also unremarkable with a pH of 7.42 and a PCO2 of 36. His COVID PCR was negative and his urine drug screen was positive for amphetamines.
So, Emily, already there's a lot to think about here. From his vitals themselves, this gentleman is tachypnic, tachycardic, hypoxic with lower extremity edema, requiring supplemental oxygen. This is already concerning, and he has evidence of organ injury with an elevated creatinine as well as an elevated NT-proBNP, not to mention his urine drug screen being positive for amphetamine, which is expected based on his history. So all of the concerns that we had based on your detailed history are bolstered by the objective data that we have so far and make us really hone in to figure out what's going on here. Do you mind going through the chest X-ray and EKG, and maybe we can think about where to go from there?
Sure. So while he's in the ED, we were able to get a chest X-ray, and it was largely normal, notable only for an enlarged main pulmonary artery. There was no pulmonary edema, pleural effusion, or pneumothorax that was noted. Regarding his EKG, showed that the patient was in sinus tachycardia. He had a right axis deviation, as well as right atrial enlargement with the P pulmonale. At this point, with the data we have thus far, we can probably narrow the differential diagnosis a little bit. So his acute left-sided heart failure and cardiac arrhythmia at this point becomes less likely, since the EKG shows that the patient was in sinus tachycardia. His chest X-ray also didn't show any overt signs of volume overload. So we can probably narrow differentials more to pulmonary embolism, given his tachycardia, his history of DVT, as well as pulmonary hypertension with symptoms of volume overload and his history of methamphetamine use. In practice, sometimes we are inclined to get a well score to see if we should get a D-dimer or CTPA. But in this case, since we had a high clinical suspicion for PE, we went straight to the CTPA while the patient was still in the ED. Given the high suspicion for PE, CTPA was obtained. And while we were waiting for that to get done, we did start a patient on therapeutic heparin drip. The CTPA showed that there was no pulmonary emboli, but the main pulmonary artery was prominent, concerning for mild pulmonary hypertension. His heart and mediastinal structures were within normal limits. There was reflux of contrast into the inferior vena cava and hepatic veins, suggested of increased right heart pressure. And there was also trace pericardial effusion. Otherwise, there was no pulmonary parenchymal abnormality and there was no airway abnormality. Since the CTPA results were negative for PE, the heparin drip was promptly held. And given the concern for pulmonary hypertension with the enlarged pulmonary artery that was seen, a transthoracic echocardiogram was pursued.
Emily, that was a great presentation so far. And I loved how when Charlie asked you earlier, what next steps do you need to do? And this is before the physical and lab and things like that. When you already were considering symptoms of heart failure, you didn't jump straight to the echo. This case beautifully highlights why we don't just do that. We want to understand the history and physical and get as much data as we can prior to getting the echo, because that will tell us what we should expect on the echo. And then if we find something different than what we would expect on the echo, then we should rethink the entire case, right? So here's a great example where we've identified the patient's dyspnea to a cardiorespiratory component. And then we said, there's probably something going on with the heart and maybe the heart-lung interface. And then you've demonstrated why you put acute left-sided heart failure lower on the differential. Obviously, it hasn't been ruled out entirely, but you've basically pinpointed this into the right side of the heart and the lungs. So now when we're going to be hearing the transthoracic echo, which is really the next step, we have certain expectations of what we would expect to see. And if we find something other than that, we'll definitely rethink this case very carefully. So Charlie, I know you just were strolling out of the echo lab. I presume you saw this echo. So what did you see and what were you thinking?
Sure did. So based on what Emily has already nicely outlined, not only the presence of a tall R wave in V1 on the ECG, as well as the rightward axis, and most recently the CT scan demonstrating reflux of contrast, which is a sign potentially consistent with right ventricular dysfunction and or tricuspid regurgitation. Going into the transthoracic echo, there's already a suspicion that something is wrong with the right side of the heart. And so we go into this examination expecting to find something wrong with the right ventricle, either dilated, hypertrophied, some evidence of pulmonary hypertension. And if we don't find that, then we have to go back to the drawing board to ask ourselves why the patient has persistent dyspnea, hypoxemia, and tachycardia. But in fact, the transthoracic echocardiogram was completed and it demonstrated essentially two key findings, which we'll expand upon later in the case. But first, I want to highlight that the left ventricular function appeared normal with maybe some concentric hypertrophy, a finding that often represents repeated exposure to high afterload, just like in patients who have chronic hypertension. But the second key finding is that the right ventricle and the right atrium both appeared severely dilated with evidence of RV systolic dysfunction. And this is something that we often see in patients who have long-standing pulmonary hypertension or a right-sided system that is exposed to high pressures because it's a system that's not naturally designed to pump against high resistance or high pressures. And notably, this is often commented in echo reports these days, the presence of something called flattening of the interventricular septum during diastole and or systole. We take this to mean that there's evidence of volume overload causing the flattening in diastole and pressure overload in the right ventricle causing flattening in systole. It's a similar principle to the same kind of interventricular dependence we talk about when we reason out why physiologically cardiac tamponade can be so dangerous. Now, in highlighting some of the objective data on the transthoracic echocardiogram, there are different schools of thought on the sensitivity and specificity for specific numbers such as TAPC or the RV-S prime, something called a peak lateral tricuspid annular systolic velocity. They can be used as surrogates on TTE for how much the RV is moving. And suffice it to say, in this case, not very well. These numbers were low. And we're often instructed to use these numbers to corroborate our suspicions, but to not refute them. So in this case, the absence of RV movement by Doppler is supportive of our suspicion that there's been long-standing damage to the RV, causing it to dilate and not move as well as it should.
This is all really helpful so far. And really, at this point, we can make some conclusions, right? We have a 33-year-old man with a history of DVT that was inadequately treated and methamphetamine abuse, who presents with subacute progressive dyspnea on exertion, and now is found to have the clinical syndrome of RV failure. We have evidence both from the NT-proBNP, the clinical syndrome with peripheral edema, and organ injury of elevated creatinine and AST for liver injury. And we also have an echo, a dilated RV, and we think about what are the causes of RV failure. When we think about elevated afterload in terms of pulmonary hypertension, valvular disease, preload, myocardial. We don't see any evidence of valvular disease in the echocardiograms. That's very helpful. And we don't really have anything to suggest primary RV myocardial problems, but they're certainly at play here at this point in the case, right? You could consider ARVC or other myocardial issue. But there are, in terms of Venn diagram, we have RV failure, and we also have a lot to suggest pulmonary vascular issues. This gentleman has hypoxia. He has a dilated PA on his CT. In terms of acuity and chronicity of this timeline, I'm looking at the labs now. I missed this earlier, but his hemoglobin is 19. In the absence of a myeloproliferative disorder, I would think that this suggests that his hypoxia is not as acute as one might imagine in the ED, that he has long-standing hypoxemia, probably referred to pulmonary vascular disease, causing elevated afterload and RV failure. So now the question is, one, why does he have RV failure? And why does he have likely elevated pulmonary pressures? But take me to the moment when you guys are evaluating this patient in the ED, you have the echo back. What were your next steps and what was going on in your mind?
Sure, we were fairly concerned about pulmonary hypertension, as you mentioned, but we don't really know why he has pulmonary hypertension. So we tried to obtain additional labs as well as additional diagnostics while we admitted the patient to us. Regarding his lab workup, we also sent for ANA level, which was negative. His HIV was also negative, and his hepatitis panel was also negative. Some additional diagnostics that we were able to obtain. We also got a BQ scan as well as a lower extremity duplex.
So exactly, the differential for why this individual has accrued RV failure over time remains broad. And on the echocardiogram, unfortunately, we did not have a sufficient tricuspid regurgitation jet on which to estimate peak RV systolic or PA pressures. Emily, what was the next thing that you would do to try and discern if there is, in fact, pulmonary hypertension? What is the gold standard for discerning where the pressure overload is coming from?
Yeah, based on the echo findings we saw, we actually consulted cardiology next to see if they can help us with further evaluation and possibly get a right heart cath next.
Great. And that's exactly what was done next. So based on the latest set of guidelines from the European Society of Cardiology and European Respiratory Society, the gold standard for figuring out if somebody has pulmonary hypertension is via right heart catheterization. And there's specific cutoffs for diagnosis, like the mean PA pressure has to be at least 20 millimeters mercury. For pulmonary arterial hypertension, there has to be a pulmonary vascular resistance greater than 2 Woods units with a normal or low wedge pressure, et cetera. So the formal diagnosis of pulmonary hypertension, as you might be suspecting here, is usually done in a two-step manner where patients first get a transthoracic echocardiogram to evaluate the right side of the heart and potentially estimate peak systolic pressures, but that's limited by your ability to get an adequate jet on tricuspid regurgitation. But the second step is to do a confirmatory right heart catheterization if it's indicated. And in this case, it's absolutely the next thing to ask for. And in fact, the next thing that was done. So we'll take you to the cardiac catheterization laboratory where our patient is still tachycardic with a heart rate of about 100, 105. He's still hypoxemic, requiring a few liters of oxygen via nasal cannula, and his blood pressure is still hypertensive at about 150 over 90 millimeters mercury. So following some intravenous diuresis, we found that his mean RA pressure was about 5 or 6 millimeters mercury, whereas his pulmonary artery pressures were significantly elevated at about 75 for systolics, 30s for diastolics, generating a mean PA pressure of about 50. And in the wedge position, the pulmonary capillary wedge pressure, an approximation of our left atrial pressure, is approximately 3 to 5 millimeters mercury. So at this point, we have evidence of marked pulmonary hypertension, which is not accompanied by significant elevations in the wedge pressure. But given his numbers, by thermodilution and Fick estimation, this generates a cardiac index for him of about 2 to 2.5 liters per minute per square meter of body area. And the pulmonary vascular resistance, notably, comes out to about 9 or 10 Woods units, which is, again, markedly abnormal, as it should be less than 2 in individuals with normal pulmonary vascular resistance. All right, so at this stage, Emily, we have these numbers, and I know we didn't find any significant valvular abnormalities on the transthoracic echo, and although we haven't delved into the possibility of a primary myocardial issue, what are your thoughts on what this represents, and what did we ask for next in terms of next diagnostics?
Sure. So based on the hemodynamic findings that you had described, the patient with a high mean pulmonary artery pressure, as well as a low wedge pressure, we're concerned that the patient has isolated pre-capillary pulmonary hypertension. And again, he also has a high pulmonary vascular resistance, so it's greater than 3 Woods units. So again, this would all be consistent with a pre-capillary picture. And based on these findings, a vasoreactivity test was obtained.
Great. And as you had alluded to, this is something that we do when we uncover pre-capillary pulmonary hypertension, and would not be something that we would have pursued had he had an elevated wedge pressure, that we would have felt the need to discern this. The vasoreactivity study mentioned is a maneuver we frequently do to investigate if individuals who have pulmonary arterial hypertension, PAH, might be responsive to calcium channel blocker therapy. I will say in most experiences, this happens less than 20% of the time, but we do it anyway because it determines if patients might get better on oral therapies alone. So in this young man's case, going through the vasoreactivity studies, at baseline, we knew that his mean PA pressures were about 50 with a normal or low, in fact, wedge pressure at about 3 to 5 millimeters mercury and a preserved cardiac index and an elevated pulmonary vascular resistance with high concentration of inhaled nitric oxide at 80 ppm, which actually far exceeds the recommended minimum or standard of diagnosis. His mean PA pressure did not change. It remained around 50 to 55. Similarly, his wedge pressure, cardiac index, and pulmonary vascular resistance calculated out were all about the same. So this is to say that there's no change in his hemodynamics from baseline to when he was administered nitric oxide as a vasodilator.
Right. In contrast to a positive test, which would be a drop in at least 10 points to below 40 without a change or a drop in the cardiac output.
Exactly.
And I would just like to note that what I found interesting was responders to a vasoreactivity test is actually really rare. And I saw that in some studies, only about 5 to 10% of patients with pulmonary hypertension are dominant responders. And in most cases, if they're non-responsive to the calcium channel blocker, sometimes they will just transition to other medications for treatment.
Yeah. So Emily and Charlie, at this point, really an extraordinary workup and evaluation, and you've really narrowed into the issue of elevated pulmonary pressures, and you've all but excluded group 2 pulmonary hypertension in terms of left heart or left-sided valvular disease-mediated pulmonary hypertension. And I know on the CT scan, we didn't see any lung parenchymal pathology, but how did you figure out, again, to guide management, what is the cause of his pulmonary hypertension resulting in RV failure?
I think that's a great question. And Emily, as you had already touched upon earlier, there's a number of different things that can cause individuals to develop pulmonary arterial hypertension. And my question to you is, what were your next steps in terms of figuring out what was left on the table versus what is unlikely to have caused this individual to develop pulmonary hypertension over the years?
So based on the right heart cath result, we were concerned about pre-capillary pulmonary hypertension. Some additional labs and diagnostics that we obtained included an ANA level, HIV, and hepatitis panel, which were all negative. Next, we wanted to get a VQ scan to evaluate for coronal thromboembolic pulmonary embolism, given this patient's history of DVT and not getting full treatment with anticoagulation. And in some cases, VQ scans, when compared to CTPA, does have higher sensitivity for detecting CTEPH. And I will let Charlie review some of our image findings from the VQ scan.
The ventilation perfusion scan, or VQ scan itself, is often done for individuals when etiology of pulmonary hypertension is unknown and there's a desire to evaluate for WHO group 4 or contribution of chronic thromboembolic disease. And as Emily had outlined, there's a significant pretest probability for this based on the individual's prior diagnosis of presumably provoked or maybe even unprovoked DVT. But I will say its use is limited in individuals who already have concurrent restrictive or obstructive lung pathology, or in whom the chest X-ray is abnormal, because in a lot of those cases, the imaging is not specific enough to significantly alter the pretest probability. But in this case, with our gentleman, there wasn't any definitive evidence of chronic thromboembolism on his VQ scan. So this is, in short, essentially a negative, or at the very least, a non-diagnostic study. As Emily had mentioned earlier, the diagnosis of pre-capillary pulmonary hypertension is cinched by the gold standard right heart catheterization. But all of these studies are necessary in order to eliminate the possibility of some of these rarer etiologies contributing to the development of elevated pulmonary vascular resistance. It's fair as an internist and a cardiologist to assume, based on this gentleman's history, that methamphetamine, catecholamine-related RV failure as a result of that exposure is at the top of the differential. But we still owe it to this young gentleman to make sure that the other rarer etiologies are not contributing, hence the workup, as Emily had already mentioned.
Yeah, Charlie, those are great points. And, there are two issues going on right now. One is figuring out the cause of the pulmonary hypertension, and we already ruled out some of them to help guide management for the specific etiology. But at the same time, we also have to manage the pulmonary hypertension and the elevated pressures themselves. Maybe we can go through the tools available to us.
Yeah, so just quickly talking about the treatment for pulmonary hypertension. There are 4 general categories of medications. First one being calcium channel blockers that we have already mentioned. When patients have a positive vasoreactivity test, this includes medications like nifedipine, diltiazem, and amlodipine. The second class of medications are endothelin receptor antagonists, which includes medications like macitentan, which inhibits binding of endothelin, a vasoconstrictive peptide. The third class of medications is phosphodiesterase 5 inhibitors, as well as guanylate cyclase stimulators like sildenafil. By inhibiting the phosphodiesterase 5 enzymes, it causes vasodilation through production of nitric oxide and cGMP. And our last class of drugs are prostacyclin analogs or prostacyclin receptor agonists, which are produced predominantly in the endothelial cells and induces potent vasodilation of vascular beds. So most of the time, these medications are started in combination therapy, and often patients follow with a pulmonary hypertension specialist for ongoing management.
And Emily, it is considered standard of care now for individuals who have pulmonary arterial hypertension to often consider combination therapy. Sometimes you'll see ambrisentan and tadalafil, for example, combined as initial therapy for these individuals who present in their index admission, haven't taken medications before. I do believe it's considered a class 1 indication to start multiple of these medications at the same time based on at least one trial that they did in the pulmonary world, Ambition, to look at if people did better based on combination therapy initiation. And the answer in short was yes. And so in differing levels of class of recommendation, we tend to start or recommend starting multiple agents as the patient can hemodynamically tolerate them.
So far, we have a young gentleman with a history of DVT presenting with signs of dyspnea as well as lower extremity edema. We have a right heart cath obtained showing pre-capillary pulmonary hypertension with negative vasoreactivity tests. So we consulted our pulmonary hypertension specialist, and the patient was started on sildenafil 20 milligrams every 8 hours, as well as spironolactone and Lasix for additional diuresis. After a few days in the hospital, the patient reports overall symptomatic improvement after aggressive diuresis and was successfully weaned to room air. His lower extremity edema improved significantly, now with only residual trace lower extremity edema, and was able to ambulate without any issue. Prior to discharge, the patient was counseled on all his medications that were started, including diuretics to treat his symptoms, as well as medication for pulmonary hypertension. And he was instructed to follow up outpatient to obtain a sleep study, as well as pulmonary function tests to continue to work up his diagnosis of pulmonary hypertension, as well as stopping to use methamphetamines. Unfortunately, we saw that the patient represented to our hospital about 8 months after he was discharged with dyspnea and lower extremity edema, basically symptoms that were very similar to how he presented to us the first time. And these symptoms were concerning for exacerbation of his underlying pulmonary hypertension. Per the note that we saw, he was reportedly off all medications, including sildenafil and diuretics, but he has stopped using methamphetamines altogether based on that encounter as well. And it seems like he had some difficulty with insurance trying to follow up with his in-network pulmonary hypertension specialist. So at this point, the final diagnosis for our case is methamphetamine-associated pulmonary arterial hypertension with right heart failure.
Emily, now that we've identified that this patient's symptoms are from pulmonary hypertension and our working diagnosis is methamphetamine-induced pulmonary hypertension, can you tell us a little bit more about methamphetamine-induced pulmonary hypertension and see how that correlates with our patient?
Sure. So methamphetamine increases catecholamine activity with direct effects on cardiac and vascular tissue, which is thought to be the primary mechanism underlying the cardiotoxic effects that the drug has. Methamphetamine use is associated with vasoconstriction, pulmonary arterial hypertension, atherosclerosis, cardiac arrhythmias, as well as cardiomyopathy. And chronic use of methamphetamine has been associated with remodeling of cardiac tissue. There's been multiple retrospective cohort studies showing that patients with pulmonary hypertension were more likely to have a history of methamphetamine use. Additionally, meth-associated pulmonary hypertension was more commonly seen in patients who inhaled the drug through smoking, which was how our patient was using methamphetamine. There is also increasing prevalence of methamphetamine-associated cardiomyopathy. Specifically, methamphetamine-associated heart failure presents with increased severity of heart failure symptoms, longer inpatient stays, as well as more hospital readmissions compared to non-methamphetamine-associated heart failure. And as seen in our case, diagnosing pulmonary hypertension is difficult, as signs and symptoms are often nonspecific. The diagnosis is often delayed because the presenting features are frequently attributed to age, deconditioning, or any other coexisting medical condition. It is estimated that more than 20% of the patients have symptoms of pulmonary hypertension for longer than 2 years before it is recognized. And patients typically present with exertional dyspnea and fatigue, chest pain, fluid retention, and weight gain, as well as syncope in more advanced cases. And because of these nonspecific findings, it is really important to have a high clinical suspicion, like we did in our case, for pulmonary hypertension. So we can do the workup first with Transthoracic echocardiogram, followed by a right heart cath, and hopefully start patients on appropriate treatment therapies early on.
And Emily, as you had highlighted, the physiology being that of catecholamine-related hypertension, tachycardia, and increased myocardial stress leads to the development of cardiomyopathy. I will say here in Los Angeles, unfortunately, we do see a large number of these cases, and it doesn't always present in terms of isolated pulmonary hypertension, which is to say we do see methamphetamine-related cardiomyopathy presenting as isolated left ventricular dysfunction, isolated right ventricular dysfunction, such as in this patient's case, or even biventricular dysfunction in a very end-stage type presentation. We don't exactly know why some individuals have a penchant to develop left versus right-sided failure or vice versa.
Charlie and Emily, thank you so much for bringing us this important case and raising awareness about an important issue, an issue that I think many of us are going to see more and more often. Methamphetamine use, unfortunately, is on the rise, especially in hotbeds like the Western United States. And in my brief reading, I realized that not only is methamphetamine associated with pulmonary arterial hypertension, but the response to therapy and outcomes of PAH associated with methamphetamines is quite worse than PAH not associated with methamphetamine use. Probably a variety of reasons for that. But needless to say, the best treatment here certainly will be prevention and a high index of suspicion in users of methamphetamine. And a side issue that is also very important here is that on the one hand, there's recreational stimulant abuse. And then on the other hand, there is pharmacologic stimulant use for ADHD. The diagnosis of ADHD is at an incline in the United States. And the pharmacologic therapies, largely stimulants, are keeping up pace with a steep increase in prescription stimulants, especially in younger children and adolescents. And there's been really alarming data for cardiovascular and pulmonary vascular adverse effects of these medicines. And certainly behavioral therapies and safer therapies like omega-3 are advocated before resorting to stimulant use. But needless to say, we will be seeing more and more cardiovascular, pulmonary vascular impact of stimulants, be them recreational or prescription. So thank you again for teaching us about this case. Thank you to your patient for raising awareness about this issue. Phenomenal discussion. Thanks, guys.
Thank you.
Thank you so much for having us.
Strong work.
Well, my name is Jonathan Davis. I am an associate professor of medicine at the University of California in San Francisco, and I work primarily at San Francisco General Hospital, where I serve as the director of the heart failure program for the city and county's public health safety net system, the San Francisco Health Network that serves approximately 1 in 8 San Franciscans, or a little over 100,000 people who all get their primary care across San Francisco and their clinical care, specialty care, physically at San Francisco General Hospital. But I want to thank you for the invitation to discuss this really interesting case that embodies a lot of issues, both medical and otherwise, in this patient population. So first off, I think it was a really interesting case highlighting a thorough presentation, the pathophysiology, workup, initial treatment of a young man coming in with shortness of breath, found out pulmonary hypertension from his methamphetamine use. And just, I want to say a couple of things specifically about that, but then take a step back and think about some of the broader issues that the stimulant use and how that impacts both this gentleman's presentation, but also how we take care of him. The team did a really nice job of keeping the broad differential diagnosis. When patients come in with methamphetamine use or other drug use issues, it's very easy to kind of pin all of their presentation on the drug use. And to be able to keep an open mind and do a broad differential diagnosis and think about other things that could be at play here is incredibly important. And also that once you narrow in the diagnosis, in this case, to pulmonary hypertension, that not just assume it's from methamphetamine. And the team did a really nice job thinking about other things from autoimmune, chronic thromboembolic disease, and otherwise. But the key really is, what happens after the patient leaves the hospital. The team does a thorough workup, starts treatment with sildenafil, spironolactone, and furosemide, but then the patient discharges and then isn't seen or heard of again for another 8 months when he comes back with the same presentation, fortunately off methamphetamine, but not any medications, no clinic follow-up. And the key is to think, how do we address these other issues before the patient leaves the hospital? Because what happens when they leave is the single most important thing. And as we'll see, taking care of individuals, both medical and drug use issues, is that it's the everything else, that giving them a diagnosis of pulmonary hypertension and prescribing the right things, or if it's heart failure, prescribing guideline-directed medical therapy, that's the easy part. It's what happens when they leave the hospital. And methamphetamine use is really on the rise across the country. In California, as an example, from 2008 to 2018, the methamphetamine-associated admissions overall increased from just over 1% to 8%, which is a 600% increase in that 10-year span. At our safety net hospital here at San Francisco General, there's an odds ratio of 3.6 that methamphetamine use being an independent predictor of heart failure readmission. And this is a problem, and it's rising nationally. Kind of how do we think about the different things at play here? Because it is a tremendous burden to the healthcare system. Recent studies have shown that this cost and annual inflation-adjusted hospitalizations for methamphetamine-associated diseases was almost 900% from this 2008-2018 time span, from $41 million to $390 million. It's a problem. And folks with co-occurring stimulant use disorder and heart disease face a lot of barriers. And I think it's really important to step beyond just the pulmonary hypertension or the cardiomyopathy and thinking about those barriers, because there's several issues at play. The thing that comes to mind, among others, I'll talk about a few things briefly, is that there's bidirectional stigma. There's stigma from providers to patients. Oh, it's so-and-so's here again with their stimulant use and their heart failure, their pulmonary hypertension, they're not taking the medications, and a lot of biases that exist on the part of the providers. Further, that there's directions, the other direction, patients coming in feeling, oh, they're not going to take me seriously. They don't want to treat me. They're just going to think I'm just a drug user and they're going to blow me off. And this really puts us an estrangement in the care lines between patient and provider. And these folks are sick. The rates of acute care utilization, urgent care, emergency department center are significantly higher than other individuals who don't use drugs, while the rates of outpatient engagement are low. And we don't exactly know how this drug causes these different diseases. As was mentioned in the presentation, we don't know, is this a dose response? How much use is enough to cause pulmonary or cardiac toxicities? How does a rate of drug use, the method of drug use, whether injected or inhaled, predispose to different things? Also, this population has very high issues of co-occurring mental health and other substance use issues. They're often under-resourced socioeconomically with poor social support, housing, food insecurity issues, all impact outpatient care. And these social determinants help disproportionately affect this population and drive an even higher rate of acute care utilization, heart failure, and pulmonary hypertension presentations, morbidity, and mortality. And so we really have to take a broader look at how we think about these folks from a multidisciplinary perspective. We're very fortunate. Marlene Martin started an inpatient addiction care team. That's now a multidisciplinary team at our hospital with nurse practitioners, medical MDs that are board certified in internal medicine, case management, social work that can meet patients in the hospital to begin to discuss their stimulant issues. But you have to have a way to think about what's going to happen when the patient leaves and trying to plug patients in with resources before they go home. Make sure they have that primary care appointment. It's on paper. There's a lot of these folks don't have telephones, so don't rely on a post-discharge follow-up phone call to connect them. Make sure this is down before them. Schedule in the clinic's phone number if they do have a phone. Program it in the patient's telephone before they go. Think about how they're getting their medications. Do they need Medisets or bubble packs prepared on discharge? They need 30-day supply instead of 90-day supply because their meds are at risk of being lost or stolen. And if you give them a 90-day supply, which again in the general population can improve adherence, if they're more at risk of having their medication stolen or misplaced, then if you give them a 90-day supply, it makes an even longer time between availability for the medication to be refilled. So thinking about all these issues that the patient's facing before they leave the hospital, and that has to be just as important as making the medical diagnosis of pulmonary hypertension, heart failure, what have you, is thinking about the social determinants of health, trying to plug them in with resources, and to be mindful of this as we set up their discharge planning in order to really thoroughly and thoughtfully engage this patient population and get them the care they need the most. But again, thank you so much for having me comment on this, and take care.